I will do a general talk, and because the title is very general. So starting with the beginning, which is thanks to Hervé de Ramon, who should be here with us. We invented this technique in Amiens, at the north of Paris. So where do we stand from this start point? So now there are plenty of devices, as we have seen together. So the most well-known is balloon kyphoplasty. This is an example of balloon kyphoplasty. And this is, for example, a patient, and you can see there is some degree of kyphosis. And this is what is doing kyphoplasty, is first putting the balloon, as you see, with a good result. You see the increase in height of the vertebra, which is from this start point, which is very dramatic. But when you retire, when you withdraw the balloon, then you lose maybe half of the gain in height. So this is a problem with kyphoplasty. You see there is some height loss here with gas inside, with a cavity. And then you fill it with cement, as shown here. And this is a final result, which is not bad, with a rather good gain in kyphosis angle. So from this start point, there are now plenty of other devices. I won't go through. The previous author did it. So the problem is that we have no study which is able to compare these devices. Everyone is using one device in his institute, so we do not know which is the best of all these devices. This is, for example, the VBS from the Puissantesse, and an example of the VBS working. And this is the Vessel X, which is shown outside. I think it's a very nice device because the cement is able to go through the pouch, and this is interesting, as shown by the previous author. So the advantages of these devices is that you create a cavity with bony walls, and then you decrease the pressure inside the fracture, so you have lower pressure when injection, and you have less risk of cement leakage. And this is especially important when you deal with vertebral metastasis. For example, in such a case where you have no more cortical bone, I think this is a good indication to use balloon kyphoplasty, and this is my indication how I use. It's the time I use it, and you see, for example, a result. To be honest, I should not do this anymore because, as shown by previous author, this is working for maybe 6 months, one year, and then you have a problem of stability of the spine. So in such cases, you should use together kyphoplasty and orthopedic percutaneous fixation. But to reduce the risk of cement leakage, the device is not the only problem. There are many, many other issues which are conditioning the risk of cement leakage. And of course, you have the continuity of the cortical bone. So the risk is much increased in metastatic disease, for example, compared to osteoporosis. But the cement viscosity is very important. As well as the experience of the operator, and also the type of imaging modality you use to check for cement leakage. For example, if you use X-rays, you will find 30% of cement leakage. But if you use CT scanner systematically, you will find something like 80% of cement leakage. So it's very, very, very frequent. So this is the influence of viscosity when you inject in a prototype of vertebra. So you see, this is how is distributed low viscosity cement, and this is the way it's distributed within the vertebral body with the high viscosity cement. And I think that using high viscosity cement is a very big improvement. I was used to select the F20, which is a brand from Technimed. Then now I'm using Vertesem Plus. I think it's a very nice cement. I have no interest. I just tell you how I do it. No interest at all. This is from Depuis Synthèse. And there are new cement which are even have an even higher degree of viscosity. For example, Confidence from Depuis as well, and high viscosity plus from Technimed, which is a brand new cement as well. And with this cement, you can achieve almost the same result than with using the devices. This is an example of vertebral collapse with gas inside with osteonecrosis. And you see that this is the plain vertebroplasty. And finally, you see the distribution of high viscosity cement is doing like a ball. It's not the same things that the same distribution that with low viscosity cement. And finally, this is the result you can get, and with increase in height without any device. And I'm not sure that devices are superior to high viscosity cement vertebroplasty. And I would be interested in doing and I plan to do a study to compare high viscosity cement vertebroplasty to kyphoplasty using devices. Another problem is the inducing new fracture doing vertebroplasty. And because you are changing the vertebra into a stone, so there is a stone between vertebra, and this is a classical image to explain that you increase this risk. And if you look to, this is an example of vertebroplasty, and in the following months, you have a fracture of the adjacent superior vertebra. And from the literature, you can see that the superior vertebra is more at risk of fracture than the lower vertebra. If you look at the literature, you see that the risk of new fracture is up to around 20%, which is very high. And this is impressive. And in addition, most of these fractures occur within the months following the vertebroplasty. And in addition, 2/3 of these new fractures are adjacent to the vertebroplasty level. So it seems from the literature that vertebroplasty and kyphoplasty are increasing the risk of adjacent fracture. But if you look to the prospective studies, then you see that there, in most of the studies, except this was the first one, there is no differences in the rate of new fracture with vertebroplasty and with conservative treatment. And which is very important as well is that if you look at the natural history of osteoporotic fracture, and this has been done in a very nice paper by Lindsay, you see that if you take a patient with two prevalent fractures, then the risk of having a new fracture in the next year is 24%. So it's the same rate with a natural history. And another point is that the osteoporotic fracture in the natural history all occur in the same area, the thoracolumbar level. So it's my opinion, but this has to be demonstrated by studies. It's not at all sure that there is an increased risk of adjacent fracture, but this has to be demonstrated in studies. Most importantly, as has been told by Isidore first, is the increase in kyphosis due to a fracture. And we know that kyphosis by itself, it's increasing the risk of new disease, increases the risk of fall, and finally increases the mortality of patients in the following year. So it is a very important issue. And I would like to show you this patient, this woman with an osteoporotic fracture. She came with this fracture, as you see here. But if you compare, this is April, and this is November. And you see that between April and November, there is a high increase in the kyphosis. I show you the measurement. So you see in April, the kyphosis angle is 70 degrees, and in November is 26, so there's a 9-degree increase in kyphosis. And I would like to share with you this, the first preliminary results of a French national study with 20 centers, and which is called STIC-KYPHO, and we compare in a group of patients with a fracture of less than 6 weeks duration. Unfortunately, the numbers are very low because it's very, very difficult to include people in such prospective studies, as you have seen in the New England Journal studies. But you see this, you can see this. If you take patients within 6 weeks following the fracture, then you see that the degree of kyphosis angle is between 7 and 10 degrees. If you do a vertebroplasty or balloon kyphoplasty, the final result is almost no change. So it's not true that balloon kyphoplasty is gaining height or gaining angle. There is only 1 degree difference between vertebroplasty and balloon kyphoplasty. This is the result of this study. But very interesting is to look at the conservative treatment group. And you can see that this is that progressively there is an increase in kyphosis during 1 year. So almost 5 degrees of increase in kyphosis. So I show you now the other group of patients, the other study, dealing with patients with an osteoporotic fracture of more than 6 weeks, but still with edema at MRI. And you see, first look, first glance, in this study there is no control group. You just have vertebroplasty and balloon kyphoplasty. And you see that the degree of kyphosis is no more 7 to 10 degrees, but is 14 to 16 degrees. So this is my point. This means that osteoporotic fracture is a progressive disease. It's not a one-shot fracture. It's a fracture, and then it increases. This is a mean. So it's true that some patients will not have increase in kyphosis, and some other will have a high degree of increase. But this, for me, is very important. And again, you see that there is no change. What are doing vertebroplasty and kyphoplasty is to avoid the increase of kyphosis in the following year. It's not height gain. So this is important because if you look to the recommendation, to the prescription rules in the US or in Great Britain of vertebroplasty and kyphoplasty in osteoporotic fracture, the indication is not responding to conservative treatment and resisting optimal pain management. So the indication is to treat pain, which is resisting to medical treatment. And what I showed you is completely different, is to treat to avoid increase in kyphosis. So it's a new way of looking at vertebroplasty and kyphoplasty. But it's because fracture induces kyphosis and kyphosis induces mortality. But the problem is to be able to predict people who will have several fractures and we will have increased kyphosis. We know that BMD is an important factor. We know that fracture at the thoracolumbar level is a predictive fracture, and you know that the number of prevalent fracture is predictive of new fractures. But this is not sufficient. So the point is to be able to better predict new fractures and increase kyphosis, and maybe in this patient, we will be much more aggressive than we are right now. Thank you for your attention.